We've had a fantastic 3 sessions. And if you have been with us, you've heard some of the great insights that we're getting from our faculty. Next, we have our keynote speaker, Paul Cammack, who is an orthopedic surgeon at the Twin Cities Orthopedics Group in Minnesota. He did his residency at UC Davis, his medical school at the University of Wisconsin, and did his fellowship in foot and ankle surgery at the Michigan International Foot and Ankle Center. Paul is going to be speaking about the apex ankle replacement, and this keynote address and this hour has been brought to you by Paragon 28. Thanks, Paul.
Well, thanks, everyone. Thanks, Selene, for all the work in putting this together. And certainly thanks for inviting me and allowing me to participate in what so far has been a really great opportunity, some great discussions, and I look forward to learning a lot more as well. So my name is Paul Cammack. I am in practice at Twin Cities Orthopedics in Minneapolis, and I'm going to share a little bit. My talk's going to be just a little bit different. This is going to be a relatively implant-specific talk. We've heard a lot about sort of principles of treatment of ankle arthritis and some overviews of the history and the evolution of the implants themselves and design and complications and how best to avoid that. My talk's going to be a little bit more implant-specific. I'm going to talk specifically about the Apex 3D Total Ankle, go over just a little bit of design discussion, talk a little bit about the design rationale behind the Apex, how it was designed and why. I'm not a design surgeon, but I've been using it since it came out in 2020. And I've had a lot of conversations with the design surgeons sort of about their thinking and why they designed it the way they did. Talk about some of the principles and things that attracted me to this particular implant. And then I'll share some cases to kind of go over some cases sort of specific to what I like about it and why I think it's a valuable tool that we can use as we're treating patients with ankle arthritis with total ankle arthroplasty. Before I talk about my experience with the Apex specifically, just a quick shout out to my experience in general, my professional experience. As Selene mentioned, I was fortunate enough to do my fellowship at the Michigan International Foot and Ankle Center with Art Manoli. Art, who's being honored this year as one of the pillars of the AOFAS and one of the pillars of foot and ankle surgery. And I would certainly agree that Art's influence has been significant on my career and my ability to practice, and the things that I've learned, I owe certainly a lot to Art and his mentorship and influence. And all of us who work in this field, I think, can agree that Art was truly one of the pillars of our society and pillars of our practices in allowing us to treat patients with foot and ankle conditions and foot and ankle arthritis as well. Interestingly, when I was doing my fellowship with Art, it was in the early 2000s. And at the first talk, we heard a little bit about kind of the evolution of the implants and the generations of total ankle implants from the first generations that really failed miserably, the second generation, which had a little bit better survivorship and success. And then now we're on to our third and fourth generations, which hopefully are more successful and giving us more longevity. When I was doing my fellowship with Art, it was right about the time when those second generation implants were starting to show some of their weaknesses. We were realizing some of the problems that we were having with these second generation implants, and the third generation implants were just sort of coming to be more available and more popular. And I was fortunate enough to work with Art at a time when arthroplasty was really sort of going through a change from these second generation towards these third generation implants. And I've been able to and fortunate enough to sort of see some of that evolution happen in my career. And I'll talk a little bit about that as I talk about the Apex specifically. So again, a shout out to Art Manoli, one of the pillars of our society. So as we know, ankle arthritis is something that we all treat, those of us who take care of foot and ankle patients. Relatively less common than hip and knee arthritis. Obviously, ankle arthritis affects about 1% of the population. So not nearly as common as primary hip and knee arthritis. And as we've heard and as we know, the majority of the time ankle arthritis is post-traumatic. So there's usually some degree of trauma or instability which leads to ankle arthritis. Although not as common, certainly functional limitations from end-stage ankle arthritis are significant. It's studies done showing that the functional limitations from end-stage ankle arthritis are similar to patients with end-stage renal disease. So as much of an impact on your quality of life as being on dialysis if you have end-stage ankle arthritis. So those of us who take care of this condition know it's debilitating, and patients with end-stage ankle arthritis are really quite limited in their ability to live a normal life. And we really have a great opportunity to kind of help help alleviate some of those symptoms and improve patients' quality of life. I tell patients all the time, ankle arthroplasty is one of my favorite operations to do because it really can affect a meaningful change in people's lives. Ankle fusion and total ankle arthroplasty are both predictable pain relievers and can provide predictable functional improvement in folks with end-stage ankle arthritis. And one of the discussions I had with Art often as a fellow, as we were talking about this sort of change in generation of ankle arthroplasty implants, Art would tell me all the time, we've got to be able to do better than fusions. Ankle fusion is a good operation. Those of us who treat this still do a lot of ankle fusions. And ankle fusion it can provide predictable pain relief. We obviously are having these discussions because we know that arthroplasty is a good alternative and has some definite advantages over ankle fusion. But it's important that we realize that our arthroplasty has to be equal to or better than a fusion in order to provide pain relief and functional improvement for our patients. As we know, ankle arthroplasty is becoming an increasingly popular option for the treatment of end-stage ankle arthritis. Those of us who've been in practice for a length of time have seen just this dramatic increase in the number of ankle arthroplasties that are being done. Old data from 2013, but between 2007 and 2013, which is sort of when we were sort of transitioning from the second to third generation and fourth generation implants, we saw a 12-fold increase in the number of total ankle arthroplasties that are being done for end-stage ankle arthritis. And there's continued data to show that the trend is continuing to increase. There's more and more ankle arthroplasties being put in for arthritis. And certainly in my own career, in my own practice, I would say the number of arthroplasties I do compared to the number of fusions, it continues to increase, and the number of fusions that I do is continuing to decrease. We're also having more data to support expanding indications for total ankle arthroplasty. Certainly in my personal experience, when I was starting in the arthroplasty practice, I would really limit my total ankles to patients who had minimal, if any, deformity. Patients had to be old enough to where I wasn't worried that they were going to have problems with failure where I'd have to go back and revise it. It was older patients, lower demand, and minimal deformity. And as time has gone on, I think we've all seen that we're safely and reliably able to tackle patients with more deformity. We're more and more comfortable putting these arthroplasties in patients who are younger. The indications just continue to expand, and we're getting more data to support the use of arthroplasty as a viable option in a broader range of patients, certainly not as limited as it once was. So as we think about total ankle arthroplasty, long-term survivorship still remains a concern. We've heard about the survivorship of total ankles. We know it's not as high as hips and knees. They don't last as long as our hip and knee colleagues. The arthroplasties there. Again, some old data showing 5 to 10 year survivorship anywhere from 83 to 90%. So survivorship certainly remains a concern and something I could discuss with patients always, something we want to make sure that we're continuing to work on improving as we're looking to implant design and how we put these implants in to try and make sure we're maximizing survivorship. And as we've heard, there's plenty of data to suggest that we still have problems with surgical complications, as in any surgery. Complications in total ankle arthroplasty remain a concern. One of the presenters earlier talked about the clear data that the more ankles you do, the less number of complications you tend to have. We certainly want to be able to make sure that as we have instrumentation systems and surgical techniques that we're able to do this predictably and reliably with as few complications as possible. So why do they fail? Why do we have problems with failure of total ankles? And this is, again, an old study and old data that suggests that one of the primary reason we have failure of total ankle arthroplasties is aseptic loosening. Similar to our hip and knee colleagues, aseptic loosening remains the most common cause for ankle arthroplasty failures. As we talk about this, I've talked to some of our colleagues who do a lot of ankle arthroplasty. I think aseptic loosening is a problem. I think a lot of the early failures with loosening is aseptic loosening or realistically lack of initial bony ingrowth. I think one of the problems we have with ankle arthroplasty is that occasionally we won't get good bony ingrowth initially, and then we really don't have a stable implant to begin with, and that can lead obviously to early failure in aseptic loosening. Other complications, again, similar to what we see in other arthroplasties, but as we evolve and as we are continuing to improve and refine our technique and refine the implants that we're using, hopefully we can have less and less problems with aseptic loosening and get a longer survivorship for these implants. So our goals of total ankle arthroplasty certainly minimize operative complications. Can we put them in reliably? Can we reliably put the implant in and reproduce our preoperative plan, minimize the risk that we have a surgical complication, and then maximize patient satisfaction? We want to make sure that patients get that functional outcome that we're looking for. Again, we have the bar of comparing against fusion. We want to make sure that our patients feel better, that they get the pain improvement and functional outcome that they're looking for, and make sure that that pain relief and functional improvement is long lasting. And again, maximizing survivorship. As I'm counseling my patients about total ankle arthroplasty, I tell them, we get asked all the time, how long is this going to last? When am I going to have this redone? Is this going to last me for the rest of my life? The discussion I have with my patients is about 10 to 15 year survivorship is what the literature would tell us. Is this accurate? Can we do better? Again, our implants continue to evolve. Our techniques continue to evolve. We think we're getting better at avoiding complications and putting this in reliably. And hopefully as we go forward, we can have conversations with our patients that the survivorship continues to improve. So this is actually the first total ankle that I did in practice. This is the old Inbone 1. This is an 84-year-old woman who came to me. She'd had a previous subtalar fusion, developed ankle arthritis, and was pretty symptomatic from it. The first implant I did in practice was the old Inbone 1, and this was about 2 years ago. At that point, she was 14 years post-op. She's probably about 15 and a half now. She had come to see me because she broke her other foot, and I asked her if she'd be okay with me x-raying her ankle on the right. And she asked me, well, why would you want to do that? It feels fine. I'm doing well. I'm not really having much pain. I'm walking on it. I don't really even know what's in there, but I convinced her to let me take an x-ray. And as you can see, 14 years later, it still looks pretty good. The implant appears well ingrown. It's well fixed. There's been no subsidence. It seems to be in the same position that we put it in 14 years earlier. Certainly the medial malleolus, there's a little concern there. We can see a little bit of osteolysis around the medial malleolus. Makes me a little bit nervous, but 14 years in, she's happy, and I was certainly happy to see. And I would say in this situation, goal was achieved. She's got a stable implant with good pain relief and a good improvement in her functional outcome that's been long lasting. At age 84, I'm hoping that this lasts her as long as she needs it, and we're not going to have to talk about revising it or doing anything more. So this is another patient of mine. This is a 58-year-old man who had developed ankle arthritis from post-traumatic situation. He'd had a previous fracture and then had ended up with post-traumatic arthritis. I did a primary ankle arthroplasty on him using a different implant. He came to see me at his 6-month post-op visit. He was happy. He was feeling good. His x-rays looked pretty good. I was happy with how his implant was looking. It appeared to be stable. I thought it was pretty well ingrown. He wasn't really having much pain, walking, not much swelling, and really felt like he was doing very well at 6 months post-op. He came in to see me about 18 months later, about 2 years post-op, and these were his x-rays at that 2-year post-op visit. He said, I'm still doing okay. It's not as good as it was. I'm having a little bit more swelling. It's good, but it's not great. And as we can see on these x-rays, now his tibial component is subsided. It's loose, and he's certainly he's having more symptoms than he was as his 6-month post-op visit. And those of us who do ankle arthroplasties hate to see this. Now he's got a component that's loose. He's only 2 years post-op, and now we have to decide what we're going to do about that. Certainly he's going to need some more surgery to convert this to a revision prosthesis or convert it to a fusion. So as I was looking at his x-rays at this 2-year post-op visit, I'm asking myself, well, what went wrong? What happened here? How come this subsided? Was it bad technique? Did I not put it in well? Did I do something wrong in terms of how I put it in? Was it the wrong size? Was it oversized? Was it undersized? Was it malaligned when I put it in? Did I choose the wrong implant? Certainly this implant that I use has a good track record. It's been around for a while and definitely has a good track record. When our surgeries go bad, we often like to try and blame the patient rather than blaming ourselves. So was it something that he did that caused it to go bad? But he was a reliable guy, healthy guy, followed the rules, did what he was supposed to. And unfortunately, after we went through all of this and we worked him up for infection and other causes for failure, the implant just failed. It subsided, and I never really could come up with a good answer for why it failed. But again, this is something none of us want to see. We certainly want to try and avoid this at all costs, because now we're having to go back and do a revision surgery. So when we talk about options for total ankle arthroplasty, we've heard a little bit about this. This is a partial list of the options that we have today. There's lots of different component designs. There's fixed bearing versus mobile bearing. We've heard a little bit about that earlier. Varying geometry of the implants. We have stemmed implants and implants with more of a keel or a barrel design. The trabecular metal implant, which goes in from a lateral approach. In my career, my history and my experience has been with all of these shown except for the Zimmer. I don't have any personal experience with the trabecular metal implant, but I've had an opportunity to use all of these, and there's certainly things that I like and don't like about all of them. So we have certainly lots of options out there, and ultimately we want an implant that works well in our hands and that we feel like we can put in reproducibly and predictably. So I'm going to talk a little bit about why the Apex 3D and why I became interested in the Apex, and then what has led me to use it as my go-to for primary total ankle. So really 3 things that led me to take a look at it as I was evaluating the implant I was using in my everyday practice. The component design, the design of the tibial component and the talar component. I'll talk a little bit about, again, the design rationale and some of the features of the design that spoke to me as I was thinking about my ankle arthroplasty practice. Instrumentation, all of us who put these in, we want the instrumentation to be user-friendly. We want it to be predictable, to work well in our hands. We want it to be as simple as possible when we have a surgical tech who's working with us who may or may not have done a lot of total ankle arthroplasties. If it's onerous and intimidating for them, it certainly makes our job a little bit harder. And then versatility, options to treat varying conditions, to deal with varying deformities, and to bail myself out of a difficult situation if that happened. The Apex sort of offered some versatility that was attractive to me, and I'll talk to you about that a little bit and share a case of where I was able to take advantage of that versatility that's sort of built into this system. So I'll talk a little bit about the tibial component design. And the Apex tibial component has both an arc and a flat design that's available. This is a picture of the arc design, and a few things about the design of this tibial component that I thought were interesting and potentially helpful, and something that I would like in my practice. As I've gone through my experience in total ankles, and as I've had experience with a number of different systems, certainly I feel like I've had a little bit of a shift in what I worry about. We always worry about the implant in growing and it remaining stable. And for a long time, my biggest concern and what I was most paranoid about was failure on the talar side. I thought, I was worried about AVN of the talus. We saw some cases earlier of failure where the talus has developed AVN. And certainly that concern is not gone away. But as I've practiced longer and put more of these implants in, I feel like I've seen just as many problems, if not more, on the tibial side than I have on the talar side. Probably again with this lack of initial ingrowth or early loosening of the tibial component. So as I was looking at the Apex and thinking about what it had to offer on the tibial side, there was a few things specifically that sort of spoke to me that I'll talk about. When we talk about implantation of a total ankle arthroplasty, again, we use these typically without cement. So we're looking for initial stability of the implant. We want to be able to impact the implant and put the implant in place and have this excellent initial stability where it's well seated and we're not worried that it's going to shift or move, and allow our patients to start loading it and encourage the bony ingrowth that ultimately will allow to long-term stability. So as I'm thinking about the talar and the tibial side, I'm thinking about good initial stability as the implant goes in. I want to walk out of the operating room and know that that implant is stably fixed. And then also to be confident that we're going to get some good bony ingrowth to lead to that early and long-term stability of the component. And the tibial component has the arc design to it. And this spoke to me a bit in terms of the initial stability of the implant. With the arc design, there's a little more coverage in the way it fits. There's a little more rotational control. As the arc sits in the tibia, you create the arc on the tibial plafond. And then obviously the implant matches that arc. And by using that arc design, I felt like I was potentially had the option of having more initial stability, worry a little bit less about rotation as that implant is inserted, and hopefully walk out with a little bit more confidence that that implant is well fixed right from the get-go. The ingrowth surfaces, this is a 3D printed prosthesis. So the pores on the backside of the prosthesis are 3D printed rather than plasma spray. There was a lot of research done in talking to the design surgeons about trying to come up with the best pore size to sort of maximize the opportunity and the ability for bone to grow into the pores. So 3D printing is an option for bony ingrowth rather than just a plasma spray where we spray a plasma coated surface on the back of the implant and hope for ingrowth there. Certainly something that is hopefully attractive and hopefully helpful in terms of getting that bony ingrowth and then long-term stability. The vertical pegs spoke to me. I've used implants with keels and with sort of angled pegs, and conceptually, it makes sense if I'm going to have my patient loading the ankle early. I want some vertical fixation. We need some fixation to control rotation again as we insert the implant. But the vertical pegs seem to make sense as we're loading the implant. The patient then is transferring that load, not to the pegs necessarily, but into the surface area of the tibial component so that we can take advantage of Wolff's Law and get as much bony ingrowth there as we can. This design is specifically, the pegs are relatively small because they're there to achieve sort of that rotational initial stability. And the design surgeons felt like we didn't need a lot of real estate in order to get that rotational stability. And there's purposely not an ingrowth surface on the pegs themselves. They wanted to maximize the real estate for ingrowth onto the tibial tray itself and not have bony ingrowth onto the pegs and then leading to some stress shielding on the implant itself. So really designed to have no bony ingrowth on the pegs, but rather bony ingrowth on the entire surface area of the tibial component itself. And that spoke to me in terms of, again, that initial stability and not compromising that initial stability, but still hopefully maximizing that long-term stability by the bony ingrowth into the tibial tray. It also has ingrowth surfaces on the shoulders and the edges. The art design has the shoulders are 3D printed, as you can see on the diagram as well. So are the edges. Again, as the implant goes in, this has really a very sort of tight fit, and that initial stability is really good. And then you've got, again, more surface area to allow for ingrowth on sort of the edges of the medial and lateral gutters and the shoulders of the prosthesis as well. And anterior to posterior coverage, we know that the best bone for seating our tibial tray is on the cortical bone, both anteriorly and posteriorly. I always wondered why we didn't try to get as much coverage as possible when we were inserting our implants to really take advantage of that good cortical bone anteriorly and posteriorly to minimize the risk of subsidence. As I look at my case that I showed earlier, I wondered if I didn't really have it seated well on the cortices, and then that for whatever reason that allowed it to subside. So making sure we have plenty of anterior to posterior coverage so we can really get that implant seated on good cortical bone, and then also minimize the risk of a bunch of overhang or underhang if we do have to go bigger or smaller. Talk a little bit about the design of the tailor component. It offers both the flat and the chamfer option. Could have a long discussion about whether or not a flat cut talus or a chamfer talus is better. I think ultimately it's really a philosophical discussion if you're a believer in a flat cut or a chamfer cut on the tailor side. I tend to be a chamfer cut believer, and so I like the option of having a chamfer talus, but certainly the flat cut design is available and works very well also. There was a lot of design that went into the articulation to try and match the articulation of the native talus, the axis of rotation, the geometry of both the medial and lateral part of the talar dome is tried to match the normal articulation of the native talus as much as possible. And it's a semi-constrained talar component as well. So we heard early on that obviously the ankle joint is not a hinge. We don't want too much constraint. If we have it too loose, if there's not enough constraint, then we have problems with early failure as well. So a semi-constrained prosthesis, hopefully just enough constraint to allow for some freedom of rotation as the ankle is going through range of motion, but not so loose that we have problems with early failure there. The polyethylene was something that spoke to me as well. As I was thinking about my ankle arthroplasty practice, I always asked myself why I was doing ankle arthroplasties using the same bearing surfaces that my hip and knee colleagues were using in the 70s and 80s. And they've had several advances in how they think about polyethylene and other bearing surfaces. Our old early second and third generation implants, I use polyethylene that is an old version of the polyethylene, and the Apex is one of the prostheses, and there are several others on the market now as well that have highly cross-linked vitamin E ultra high molecular weight polyethylene. And not to go into a polyethylene discussion necessarily, but when we have this ultra high molecular weight polyethylene and then we highly cross-link it with the vitamin E included to suppress the generation of free radicals, which can cause oxidation, that consequently improves the wear resistance of the polyethylene. So having an option to have this ultra high molecular weight polyethylene was certainly something that spoke to me about this implant specifically. Those of us who do a lot of total ankles, we hope for the day when our biggest problem is polywear. I think we're still at a point where we have some other challenges that we're working on to try and make sure that we get, again, that initial good stability and hopefully we get to a point where what we worry about most is the bearing surface, and that's the biggest challenge that we have to face. But certainly having a modern polyethylene, I think, is important as our implants and our surgical techniques tend to get better and better. It has a universal locking mechanism that keeps the polyethylene centered over the talus. I'll talk about that just a little bit later when I talk about sizing options and how the polyethylene allows us to upsize by 1, so we can actually mismatch the talus and the tibia by upsizing the talus by 1, and we have sort of an infinite option to downsize. We could put the biggest talus, or the biggest tibia and the smallest talus in, and our polyethylene will still stay centered over the tibia. Practically, that's probably not really a concern, but certainly being able to mismatch by 1 or 2 or even 3 is potentially an option, or it's good to have that option and that versatility. Talk just a little bit about instrumentation. So there's 3 ways we can put the Apex ankle in. It has a traditional alignment guide that most of us are used to, some degree of external alignment guide that we'll use with a pin in the tibial tubercle, or the old InBone had obviously the frame that we would use, but some degree of external alignment system to allow us to align our ankle arthroplasty in relation to the mechanical axis of the limb. The external alignment guide I've used a number of times. It's not my go-to at this point, but it works well. It's relatively user-friendly. It has sort of a systematic series of adjustments that can allow us to make sure that we're paying close attention and can reproducibly make sure the ankle is put in with appropriate slope, rotation, varus valgus alignment, medial lateral translation, sizing, and joint line height. And all of those things are relatively user-friendly and easy to adjust. And we can do so systematically to try and, again, maximize the chance that we have the ankle as close to perfectly aligned as possible, hopefully, again, maximizing survivorship. When we talk about the instrumentation, one of the other things that attracted me to the system is this alignment block. So as we're putting we get our external alignment guide, or however we decide to get our alignment block on there, we can adjust the sizing and positioning in the implant, which then allows us reliable positioning and adjustment of the joint line height. This implant we set the joint line height where we think the joint line height should be. So it's not set off of some degree of some number of millimeters of resection that we do. We put the joint line height where we think we need it, and then we resect enough bone on both sides of that joint line, on both the tibial and talar side, to allow for enough room to put our implant in. But it's not that we're taking a certain amount of tibial bone or a certain amount of talar bone. We're taking as much bone as we need on either side of the joint to try and get our implant in. And as we've learned from hip and knee arthritis, and specifically knee arthritis, and in the ankle as well, as wear occurs, the joint line height changes. And specifically in the ankle, we have studies that show us as the ankle joint wears, the joint line height will usually migrate proximally. The joint line will move proximally. And there's good papers in the knee literature that suggest If we do a better job at restoring the joint line height, we restore the more normal kinematics of the joint and then maximize the survivorship of our arthroplasty. And something I think that is important, we should be paying attention to in ankle arthroplasty is restoring that joint line height. Are we putting it back where it belongs rather than just taking a certain amount of bone out from a physeal scar marker or some other marker to tell us where we're going to resect our bone? This is an example of a case where clearly the joint line has migrated proximally. If you try and adjust, if you try and just pay attention to where the wear has occurred, the joint line has migrated proximally. By using this implant, we can put the joint line right here, right at where the native joint line used to be, and then take an appropriate amount of bone from both the tibia and the talus to try and restore that more normal joint line. When we talk about deformity correction, the instrumentation with the Apex, I think, is useful and user-friendly when we talk about correcting deformity. I'm a believer in coupled cuts. I tend to couple my tibial and talar cuts as often as I can. Philosophically, I feel like if I can reduce the talus and the mortise first, so I get the talus reduced in the mortise, then I can couple my cuts. I know that I'm going to be able to get my ligamentous balancing done once I have my implant in place. My order of operations after I make my initial exposure, I'll do a medial lateral gutter debridement as I need to. I'll remove osteophytes. I'll do, if I have to do a little bit of soft tissue release in order to get the ligaments balanced. I make sure I can get the talus reduced within the mortise first. And then this is a technique I like where I'll use these transmalleolar pins to hold that talus reduced anatomically in the ankle mortise. And then I'll go ahead and couple my tibial and make my dorsal talar cut. The one nice thing about the Apex cut block is you can actually see through it. This is another system where if you have your cut block on there, it's a little hard to tell how well your talus is reduced within the mortise because we got a bunch of metal sort of overshadowing our cut block. The Apex cut block has holes in it so we can see right through it. Again, we can take a C-arm image that shows us right where that joint line is going to be with our cut block in place. And again, we can see through to make sure that the talus is remaining reduced within the ankle mortise before we make our coupled cuts. The second option we have for inserting an Apex is the patient-specific guides. We've heard a little bit about these as well. PSI is certainly a common way that lots of us like to use to put our total ankles in. The Apex has what's called the Maven system, which is a patient-specific instrumentation system to allow us to position and plan for deformity correction and positioning of our implants with sizing and positioning, all done with preoperative planning based on CT scans. Simulated weight-bearing CT of the entire tibia is what we use to make these Maven or these patient-specific guides. I'll talk a little bit about what I think the advantage is. This system uses a CT scan of the entire tibia, which is, I think, valuable. There can be deformity, obviously, at the mid portion of the tibia, rather than just CT scan of the ankle and the knee and then stitching them together and hoping that everything in between is normal. It is a decoupled system, so there's a tibial guide and a talar guide. So certainly if you're someone who likes to decouple the cuts, it works well that way, but also easy to convert it to a coupled cut system. The third option from an instrumentation standpoint is what's called the fast track system. It's basically an alternative to the traditional alignment guide. So it's the small alignment block that will sit on the distal aspect of the tibia. We'll pin it in place on the distal aspect of the tibia, and it's got the same adjustment options to allow us to try and align the implant without having to put a pin in the tibial tubercle. The pin in the tibial tubercle, not a game changer. Patients don't necessarily always complain about it, but certainly sometimes they don't like it. They're kneeling on their knee scooter and it's painful as they're going through their recovery. They have a total knee above, then you don't have to worry about getting a pin up near their total knee. So it's nice not to have to put a pin in the tibial tubercle. It's marketed as the fast track. I'm not sure fast track is the appropriate name because in my hands, it's not necessarily faster. It's certainly not faster in my hands than patient-specific guides. Is it more reliable? I don't know that in my hands it's necessarily more or less reliable, but I think it's got some good options. And there's certainly some cases where I prefer it. And if I'm not using patient-specific guide, this is actually my preferred method. Rather than using the traditional alignment guide, I'll use the fast track for doing my Apex outside of the patient-specific guide. So if I'm not using PSI, I typically use fast track. The other nice feature, and certainly something we hope we don't have to do, but if we're using the PSI system and for whatever reason the block doesn't fit quite like we had preoperatively planned, maybe there was hardware in there and the block doesn't fit like the CT scan told us it should, and we're not perfectly happy with how our implant is aligned, we can put the fast track device on and make some adjustments. We can adjust varus valgus alignment. We can raise or lower the joint line height. We can change rotation off of away from what we had planned with our PSI if we just don't feel like it's perfect. So I've had to do that maybe once in a patient who had a lot of post-traumatic deformity, had some previous hardware that I had to take out, and the PSI guide just didn't really, frankly, fit that well. I was able to use the fast track device to then make sure I had my alignment perfect before I went ahead and made my tibial and talar cuts. I mentioned the Apex has a lot of versatility. I talked a little bit about the versatility, the size options, the arc versus the flat tibia. If you're a believer in the arc tibia, you can do the arc tibia. If you want a traditional flat cut tibia, that's certainly available as well. A chamfer talus versus a flat talus, you can mix and match. You can do an arc tibia with a flat talus, an arc tibia with a chamfer. Like I said, it's all mix and match. Coupled versus decoupled cuts, all interchangeable, relatively easy to convert from one to another if you decide to change your mind intraoperatively. The size versatility also is something that I think is valuable. The tibial components range from size 1 to 6 with long options. Again, hopefully trying to maximize that anterior to posterior coverage to make sure we're sitting our tibial component on that good cortical bone. When the design surgeons were designing sizing and positioning of the tibial component, they actually had CT scans of arthritic ankles. So trying to base the sizing off of ankles with arthritis rather than CT scans of tibias without arthritis sort of maximized the options that they have now for achieving good coverage both anteriorly and posteriorly. Talar size goes from 1 to 5. Like I mentioned, because of the locking mechanism, the way the polyethylene locks within the tibial component, we could upsize the talus by 1, so we could put a 3 tibia and a 4 talus in, and then unlimited downsizing, so we could do a 6 tibia and a size 1 talus. Again, practically, I'm not sure that that's something I have ever seen or will see, but I have had several occasions where I felt like downsizing by 2 was helpful, so I have had occasions where I put in a 4 tibia and a 2 talus. They also have an anterior and posteriorly biased poly. We know certainly in post-traumatic situations, lots of times we'll have a tendency for the talus to sublux anteriorly from underneath the tibial plafond. That can be a challenge in post-traumatic pilons where that talus just wants to sublux out the front. It can be a lot of work to try and get it back. And I have had certainly with my experience other or occasions where I just really feel like I'm having a hard time getting the talus reduced under the tibia because it wants to slide out the front. An anterior bias poly is a nice tool to have in the toolbox if it does feel like that talus wants to sublux anteriorly. And I'll show you a case where I used that actually just based on the patient's anatomy and felt like I had a hard time getting the talus back underneath the tibia. So I'll go through just a couple of cases, show some of the Apex that I've done, and talk a little bit about why specifically I like the Apex in these particular cases, kind of highlight some of the features that I talked about earlier. So the first is a 72-year-old woman, progressive right ankle pain, lots of ankle sprains, probably chronic instability, developed varus arthritis. Her hindfoot's flexible. She had very mild cavus. Not enough that I felt like she needed that addressed, but certainly varus ankle arthritis and a varus tilt of her talus within her mortise. 72 years old, and not a tiny woman, but a sort of an average Minnesota-sized 72-year-old woman. So why Apex in this situation? Well, obviously, like any arthroplasty, we want good initial stability of the tibial component. She's 72. I want to make sure that that's well fixed when I put it in there. I like to allow my patients to start weight bearing early. As soon as they have skin healing, I want them to start loading the prosthesis, especially in older folks, because obviously non-weight bearing in the older population is more and more challenging. So the vertical pegs, the arc design with that good initial stability, and then the ability to correct her varus. Obviously, we need to get her varus corrected and get the alignment of the talus within the mortise appropriate and get her ligaments balanced to have a good long-term success. So Use the technique that I mentioned. We go in, we do our initial approach. We do a medial and lateral gutter debridement. I ended up doing a little bit of a deep deltoid release on her. Got the talus reduced within the mortise, used my transmalleolar pins to hold it there. Got her out of varus, and then proceeded with my apex using the traditional alignment guide. This was one of my earlier cases, so the traditional alignment guide was what we had available at that point. She ended up with a size 2 arc standard tibia and a size 1 chamfer talus, a 7mm polyethylene insert. And here she is at 6 weeks. She has, looks like we've got her well aligned. Seems like her varus is nicely corrected. And she came back at 1 year. She's walking, happy with her results. Again, feel like we got a good correction of her alignment. The prosthesis appears that it's got some good initial stability, appears like it's well ingrown. Again, she's a year post-op. We're hoping that continues and doesn't end up like my case I showed earlier, but so far so good. It looks like she's got a good fit and good coverage, and looks like she's got some stable ingrowth. She's due to come in about for her 2-year post-op, but like many of us know, oftentimes these ankle replacements, they feel good and they're not so interested in coming back to have us look at it again because they're just happy. So she's doing very well. And again, was worked out well for this particular case. Second case, this is a 75-year-old man, progressive left ankle pain. He reported to me no significant past medical history. He had some mild valgus alignment at his ankle joint. He had a neutral plantigrade foot below. His deltoid was competent. So plan was an apex 3D using the traditional alignment guide with an arc tibia and a chamfer talus. And this was an odd case. So he had his surgery done under a spinal anesthetic. We went ahead and proceeded as we normally do. We began making our tibial preparation. We got the tibial, we drilled to create the arc, made our dorsal talar cut, working on tibial bone removal, trying to get the bone out of the tibia, which those of us who do this case know sometimes can take a little while to get the bone out of the tibia. And as we're doing that, he starts coughing. He's under spinal anesthetic. We go ahead and we work on our talar cut, more coughing, more aspirating. He's having some airway trouble. The anesthesia doctor can't get the tube in him because he's having all these airway problems. They can't get him intubated. It's never a good sign when the anesthesiologist asks you, how much longer is this going to last? And basically they said, we got to get out of here. We can't get an airway in this guy, and we got to wake him up and get him out of here. So they told me, you got to bail out. We keep cement in the room, so we mixed up some quick cement. We threw a little bit of antibiotic spacer in there. We closed him up as quickly as we could, and we got him to the recovery room. Admitted him to the hospital. He told us, when I checked in on him later the day, he told me that, oh yeah, I can never lay flat because if I do, I just choke. But he didn't manage to mention that to any of the folks who were checking him or any of the anesthesia folks. So he waited a couple weeks, made sure medically he was okay. He did fine. Went back to the operating room about 3 weeks later, and then took the spacer out. And we had sort of a partial preparation done on his distal tibia, but didn't certainly want to just go back and put that arc in after having had a cement spacer in there for 3 weeks. So we took the cement spacer out. We put the traditional alignment guide back on. We changed him from from the arc tibia to the flat tibia. We went ahead and did a flat tibial cut. We used what's called the dorsal recut guide to cut the dorsum of the talus and converted it to a flat talus, and ended up with a 3 long flat tibia and a 3 talus with an 11mm poly. So a little bit thicker polyethylene on him. Obviously he was a bit of a primary revision, but still feel like we were able to keep his joint line height pretty close to where it's supposed to be. So we didn't really raise it or lower it we got his ligaments nicely balanced. So here he is 1 year post-op. Again, walking, he's happy. Looks like we've got good implant coverage. We've got what appears to be good bony ingrowth, no subsidence, obviously. Again, a year out, but hopefully this continues, and he's certainly happy with it now. Next case, this is a relatively young man, 53-year-old man, bilateral ankle pain, right greater than left, even though his x-rays look worse on the left. His right's more symptomatic. Previous collegiate NBA basketball player, and he was not a small shooting guard. He was a big guy who played down low, and he didn't get smaller when he retired from the NBA. So he was a very big man and had symptomatic ankle arthritis. He'd had a previous flat foot reconstruction done on the right side, but had symptomatic ankle arthritis on the right. So my concerns, why think about the apex for him? He was a big guy, certainly a young man as well. So I wanted to minimize the amount of bone resection I was doing. I wanted to make sure I had polyethylene that was going to have good wear resistance, because hopefully he's going to be using this for a long time. And I wanted to make sure I had sizing options to get good coverage, because again, he's a big man. So chose an Apex for him. He ended up with a size 5 long arc tibia, so 6 is the biggest. He had a 5. I was a little concerned that maybe I was going to need a 6, but a 5 fit well. We used the traditional alignment guide on him as well. So 5 long tibia, size 4 chamfer talus, 6 millimeter polyethylene. And again, here he is at a year post-op. Implant is in good position, appears to be well ingrown. He's functioning well. He's happy with it. He seems to be doing well. Again, he's now 54. So we're hoping that he is going to have this last him a long time, but time will tell. But hopefully we have, again, an implant that's well aligned and well fixed, have some polyethylene that's got some good wear resistance to it, and this will last him for a long time. This is a little bit more challenging deformity case, not necessarily deformity at the ankle joint, but deformity up above. So this is a 67-year-old man. He was involved in a motor vehicle crash in 1973 when he was 17 years old. He had an open tib-fib fracture, which in 1973 was treated with a washout and a cast. So he had IND and casting of his open tibia fracture and went on to heal it, and healed with this short, sort of bayoneted tib-fib fracture that he's had for about 50 years. Ended up obviously with significant leg length inequality, progressive ankle pain, ended up with end-stage ankle arthritis. We took some log-length standing views and actually realized that he had a bit of a translational deformity at his tibia, but really not much in the way of angular deformity. Certainly didn't want to try and do an osteotomy to cut his tibia after that length of time to correct that. And given the fact that he didn't have really any angular deformity there, we just decided to proceed with a total ankle. We used PSI for him. He had a CT scan to include his entire tibia, so we could see not only the area of the ankle, but we included that area where the tibia was bayoneted. Again, this is the case I mentioned about the anterior subluxation of the talus. His talus is subluxed anteriorly because that's where his talus wants to live, underneath of his knee. And with this long-standing post-traumatic deformity, I was concerned with an ankle arthroplasty. Am I going to be able to get his talus back underneath, all the way underneath his tibial plafond, or even should I allow it? Because that's where he's lived for the last 50 years. Should I allow his talus to sort of sit in that little bit of an anterior position and have the option to have some anterior bias poly to allow it to sit there and still have a normal articulation? So we had a Maven CT scan. This is the report we get, making sure we have him aligned based on his mechanical axis, aligned based on slope on the lateral view. And again, using the patient-specific guides, he had a Apex size 3 arc standard tibia, size 2 talus, 6 millimeter poly, and for him, we did use an anterior bias poly. It's not a great lateral view, but because he just wanted to still sit a little bit anteriorly, we used the anterior bias poly for him, and had a pretty good articulation of the talus, and wanted to stay underneath that anterior bias poly. He's now 6 months post-op. He saw me probably about 2 months ago. This is x-rays from 6 months post-op. Again, his components well aligned. He's happy. He's walking. He doesn't have any pain. He still has the leg length inequality. We talked obviously preoperatively that we weren't going to get him out of his shoe lift, but certainly get rid of his ankle pain. And he's very happy with this and doing quite well. Happy that I had the option of the anterior bias poly for this case. Last case I'll show, this is a 55-year-old woman who had an attempted ankle fusion done. She ended up with a symptomatic non-union. She hates her fusion, even though it's really not fully fused. Had talked to her originally operating surgeon that she really wanted a total ankle arthroplasty, felt that she was on the young side. And so her original operating surgeon, I didn't do her original fusion, but told her that a fusion was probably a better option for her, but she hates it and she wants her ankle replaced. So converting her, we'll call it a quote unquote fusion to a total ankle, is what she's interested in and what she's looking for. So hardware removal with takedown of her fusion, I guess we can sort of call it a takedown of her fusion to a total ankle arthroplasty. So PSI would be challenging in this case with all that hardware in there. It'd be hard to predict, that anterior fusion plate. Can you use PSI and still get a predictable, reliable, patient-specific guide that's going to fit on the anterior tibia? Certainly could have done a traditional alignment guide on her, but she says my knee hurts and I don't want a pin in my tibial tubercle if I can avoid it. So I decided to use the fast track guide for her. So took her to the OR, took her hardware out. This is an example of that fast track guide sitting on the distal tibia. We have our sizing and alignment block here, and then we go ahead and make our tibial preparation using the fast track device. There's the option of a laser that we can then attach to that tibial alignment guide. We can turn it down towards the toes. If you're a believer in referencing rotation off of the metatarsals in the foot, you can line that laser up with the second or third metatarsals if you like that as a way to assess to assess rotation. Turn the laser around and send it up her knee and try and assess varus valgus alignment to try and make sure that the laser is lining up with her tibial tubercle to make sure we're positioned in appropriate varus valgus alignment using that fast track device. Not required to use the laser. It does work well. It's kind of a cool tool to use. And I think it does help more so with varus valgus alignment than it does with rotation. I don't really use it to set rotation, but I do like it for varus valgus alignment to make sure I'm not in varus or valgus. So here she is intraoperatively. We have a video of what kind of motion she gets after she had her quote unquote fusion taken down. This is a softball fusion takedown because she never really fused her ankle to begin with. So she ended up with pretty good motion and is happy and doing very well. So in summary, total ankle arthroplasty, it's a good option for patients with end-stage ankle arthritis. Those of us who do this operation, again, I tell my patients this is one of my favorite operations to do because the pain relief that patients get, the functional outcome, the improvements that they achieve are really, in many cases, life-changing, and patients are really very, very happy. It's not a perfect operation, obviously. Continued design improvements hopefully increase our implant survivorship, increase our patient satisfaction. Specific to this implant, we have some ongoing research. Paragon's looking at this as a 10-year prospective study where we're following these patients to see, make sure that it is ingrowing like we want, make sure we're having, patients are having good functional outcomes and that those outcomes are long lasting. So that's what I have.
Awesome. Paul, thank you. So there's a question. Somebody had asked, is there any potential of the apex tibial implant being combined with a 3D tailor prosthesis?
There is. We're going to hear about certainly talks, I think, coming up later in the program about 3D printing. And, as the custom 3D printed implants and that's certainly exciting area of arthroplasty. And as we start to try and treat these problems, the apex tibial component to put a 3D printed or a custom talus in, the talus needs to match the tibia. And so you can 3D print the talus to match the apex tibial component or whatever tibial component you really like using. But I've done a handful of those, and I'm sure we'll hear more of those with more experience about that coming up later on in our program. So
can you give me your thoughts, when we look at designs across implants over the years, each generation almost has a design change from the generation prior, but there's a convergence of those designs for that generation. And yet it seems that most of these at 10 years still give us 85 to 90% success rate.
Yeah.
Okay. So what is it, in your opinion, going to be the breakthrough to get us to 90% survivorship at 15 years or 20 years? I know we don't have the answers, but just your thoughts.
Yeah, that's a good question, right? I mean, I think I don't know that I think that there's maybe one breakthrough. I think there's a lot of things, right? I think as the vertical sort of fixation on the tibial side, I think if we look at the latest generation, most of the newest implants have sort of a vertical fixation into the tibial side. I think that is, I think that's going to be I think that's important. And I think we're going to see that gives us good survivorship. I think just making sure we're paying attention to not only implant design, but as we're paying closer and closer attention to ligament balancing and making sure we're having a well-balanced prosthesis, I think that's going to help us a lot as well, right? I mean, in training in total knees, we learned that total knee is a soft tissue operation, not necessarily a bony operation. And I think the ankle is similar, right? I mean, certainly we need to do the bony cuts and make the correction, but ligamentous balancing is going to be key to getting us to that long-term survivorship. And especially we battle deformity, right? I mean, none of us, it's the rare day where we get to put in a total ankle where there's no deformity and it's straight on both sides. We're all happy if that happens, but unfortunately that's the rare case for most of us, for sure.
So that brings up the next point, and somebody's asked this question. If you have a patient who has either end-stage hip arthritis or knee arthritis and ankle arthritis, and let's just say the ankle's symptomatic as well as the other joint, which do you recommend they do first?
Yeah, my recommendation is they work from the top down, right? I think especially if there's deformity, if they have the more challenging question is what happens to the patient, and I've struggled with this, who has a pretty bad varus or valgus knee, end-stage knee arthritis with significant varus or valgus deformity that's not very symptomatic, but then end-stage ankle arthritis below that. My concern is if I replace their ankle, I align it with what I think is their mechanical access based on a bad varus or valgus knee. I put my ankle arthroplasty in, and then 5 years from now, their knee becomes symptomatic and a good knee surgeon corrects their knee alignment. Now my ankle's malaligned, right? So
Right.
That's a good question. I always tell patients you need to work from the top down, and I struggle more with the patient who has less symptomatic knee arthritis and more symptomatic ankle arthritis with significant proximal deformity, and not even just arthritic deformity, but should we be incorporating more aggressive about osteotomies and correcting proximal deformity? I think that's something that maybe we in the future we're talking about more. So
yeah, no, I agree with you. I think this is the last question. What is the youngest age you've ever considered for an apex?
Yeah, that's a moving target, I feel like, right? I mean, when I started doing ankle arthroplasty, like many of us, we sort of had hard stops. My hard stop has gone away, right? I don't really have a hard stop necessarily. I think it requires a lot of patient counseling and a lot of discussion. My youngest, I think the youngest I've put in she was 39. She had bad ankle arthritis with bad subtalar arthritis below. We know if I fuse her ankle, her subtalar arthritis is going to bother her. It's going to be a problem. And so we had a long conversation, and I told her, there's a good chance this isn't the last operation you need. But so I've under 40, I've done ankle arthroplasties under 40. I've not done any under 30.
Yeah, just to give you my perspective, and I'll shock you when I say this, but it was a very unusual case. I did a 14-year-old who had end-stage rheumatoid arthritis, was in a trial with the FDA for an experimental drug, had already had bilateral hips, had an ankle fusion, and had I done a second ankle fusion on him, he would have been extremely debilitated. Sure. So I did an ankle replacement. This was about 8 years ago, and he's still doing great with it. But yeah, it's wild.
Yeah, for sure.
All right. Well, thank you so much for that session. We're going to wrap up this hour in 2 minutes. We'll get the next hour started. But thanks, Paul. Appreciate the talk.
Yeah, thanks very much.